Well, first of all, I'm very excited about our next speaker that I'm going to be introducing, Dr. Sara Paul. She's a nurse practitioner in a private cardiology practice in Western North Carolina, and basically in Catawba County in Hickory. Now, she's been doing this type of work for over 30 years, managing heart failure. And what's so amazing about it is that she was our first doctorate of nurse practice. And of course, what she specialized is trying to get these heart failure clinics up. She's actually initiated 3 heart failure clinics, which I think is amazing. And not only she's been doing this nationally, but internationally. So we have an international speaker that I'm really excited to introduce. She's also served on multiple boards, the American Heart Association, of course, the Heart Failure Society of America. And on there, she's actually in charge. She edits some of the questions and stuff that in order to be certified. I thought that was pretty amazing. Also, a founding member of the American Association of Heart Failure Nurses. She's also on that committee too, as far as doing certification as well. There are many other things I could say about her, but one of the things I found out not too long ago is that she's an artist. She plays the fiddle, which I think that is cool. And her husband plays the banjo, and he's a physician. And I used to think he was the smartest physician in our area, but I found out now that behind every good man, there's a better woman. So without further ado, Sara Paul, tell me a little bit about why you're here.
Oh, thanks. What an introduction, Lee. I think that's the best introduction I've ever had. Thank you. Well, I've been, as you said, I've been dealing with heart failure for over 30 years. I started a heart failure clinic at the Medical University of South Carolina in Charleston in 1995, and I've been going on ever since then in only heart failure. I don't even see other types of cardiology patients, just heart failure. So as you mentioned, I've been very active in the Heart Failure Society, as well as the American Association of Heart Failure Nurses and the American Heart Association. So heart failure has basically been my life for many years now. And I've seen a lot of changes. I've seen a lot of great improvements in the way we treat patients medically with pharmacology as well as devices. And I see that patients are living longer. The number of transplants nationally has gone down, and that's probably thanks to the medications and the devices that we use. So, our goal is to help people live longer. But I noticed the conference theme, which is proactive medicine in a reactive world. And it really made me realize, what I do, taking care of patients with heart failure, is completely reactive. They already have the disease. And what primary care does is the proactive piece. And that is, our goal would be to prevent heart failure. Probably 90% of all heart failure is preventable up front by controlling blood pressure, reducing coronary disease, quitting smoking, counseling patients, helping them stop smoking, control their blood pressure, eat right, lose weight, all of those things, alcohol, drugs, all of those things come into play. And prevention could probably put me completely out of a job overall, most part. So I love the theme of the meeting. It's perfect. And I do want to talk about that in my presentation. A number of years ago, the American Heart Association staged heart failure: stage A, stage B, stage C, stage D. Stage A heart failure are patients who have no heart failure, actually, no structural disease. They are people who have a risk for heart failure. And those are the people that I think should really be captured. And we should work very hard to prevent them from moving on to stage B, where there is structural heart disease, but no symptoms. And then stage C are patients with structural heart disease and symptoms. And then stage D are patients with end-stage heart failure, who either are going to go on to hospice or for advanced therapies like the ventricular assist device or transplantation. So
I think that's really exciting. I can't wait to hear your lecture and complete, and we don't want to give away too much of the secrets and stuff that you'll be talking about. But I think you're totally right. This is what we're about. Can we prevent things? I think there's value in prevention. not a lot of money in prevention because, you don't do a lot of procedures and people aren't admitted and stuff like that. But this is what we're supposed to do, is try to prevent. A few quick questions I want to ask, just to see what you're going to be actually going in more detail. It was sort of interesting talking about sudden death and heart failure. And, I know sudden death was, woo, that was something when in my training, we all dreaded if somebody had a history of sudden death, and then that their rate of survival was a lot worse. What is the association? Is there something there that we could elaborate on?
When a lot of people think of sudden death, they think of myocardial infarction, which is the cap of an atherosclerotic plaque that breaks off and travels downstream and obstructs coronary blood flow, causing a myocardial infarction, or a sudden bleed and a blood clot in a coronary artery that suddenly obstructs blood flow. That's what we think of causing sudden cardiac death. But in heart failure, that is not so much the case. In heart failure, sudden cardiac death is more secondary to fibrosis of the myocardium. I'm looking at a couple of the notes that I made. Fibrosis of the myocardium, as well as electrolyte imbalance, because the neurohormones can promote potassium depletion, and we can see electrolyte imbalance. So there are a number of things that cause sudden death in heart failure that are not what we usually think of causing sudden death. And more we're discovering that it's not just ventricular arrhythmias that are causing sudden death. It is PEA, pulseless electrical activity, and asystole. So, I was taking care of heart failure before we had defibrillators. And I remember working with the early defibrillators. And now we think we're in safe territory with defibrillators, but fewer tachyarrhythmias are causing sudden cardiac death and heart failure because of the great medications and the great devices that we use. Excluding defibrillators in patients who are on the right meds and maybe have a resynchronization device, which is a biventricular pacemaker, those patients have at least about a 40% reduction in sudden cardiac death, even in the absence of a defibrillator. So we see a lot less sudden cardiac death in patients who are appropriately treated in heart failure. In fact, overall sudden cardiac death and heart failure is down about 44% since the 1990s. So, we're doing things right. Of course, it's more common in patients with ischemic disease, less common in patients who have non-ischemic cardiomyopathy. But patients are dying from electromechanical dissociation, PEA, or profound bradyarrhythmias or asystole. And a defibrillator does not help in that circumstance. So we can't sit back on our laurels and be comforted that, patient has a defibrillator, they'll be okay, when these other rhythms really are not amenable to treatment from a defibrillator. And so
about medications, I think that's something, and don't tell us the whole story, but more and more medicines that we use for other disease process, we're starting to find out benefit, and it used to be sort of, maybe it's an interesting thing, let's say guidelines, but now it's starting to move into standard of care. You have to justify why not. Can you elaborate a little bit on these medications?
Yeah, you may have to justify why a patient's not on a medication, but some of these newer medications are very hard to get because they're very expensive and you have to jump through a number of hoops to get them. So ACE inhibitors were, of course, the foundation, the first drug that showed benefit in mortality in heart failure, and then beta blockers. And beta blockers also reduce sudden cardiac death. So they've been very beneficial in reducing mortality. Then we looked at the mineralocorticoid inhibitors, such as spironolactone and eplerenone. And so those were the guidelines right there for a very long time. And then now SGLT2 inhibitors are clearly beneficial in patients not only with reduced EF, but preserved EF. So studies have come out recently that have shown us that even if the patient has a normal ejection fraction, that SGLT2 inhibitors seem to be beneficial. And so that's one of the first drugs actually for preserved EF that has shown benefit in mortality. So,
unless you were a diabetic a couple of years ago, there's no way you could have got it approved. But now I think, at least I'm finding insurance companies are paying for it, especially if they have an EF less than 30. But I like what you just said, is that maybe we have to be more proactive and not wait for it to get down to a point where half their quality of life is compromised because of their heart failure. But I like that. And I know you'll be talking about that as well. You know, the other thing is, one of the things about cardiomyopathies, and I remember in med school and stuff, we were having these different types of, you know, heart failure. You know, was it dilated? You know, was it hypertrophic? Things like this, and now you guys are talking more about, you know, preserved ejection fraction versus compromised ejection fraction, and then there's somewhere in between, the mid range. Can you just give us a little bit about that? And I don't want you to take away from your whole talk, but I think
Yeah.
that's, some of us still find it a little bit strange of, you know, wow, heart failure, that means it's not pumping well enough.
Right. You know, a lot of people, well, years ago when I started, there was either systolic or diastolic heart failure. And it's just not that simple. It's not that simple. There's heart failure with a reduced ejection fraction, considered below 40 to 45% is considered reduced ejection fraction. And then preserved ejection fraction is over 45, 50%. So what about those patients whose ejection fraction is like between 40 and 50? And those are called mid-range. And if the patient has had a reduced ejection fraction that improved to a mid-range, that is heart failure with reduced EF improved. It's not the same as someone who never had a reduced ejection fraction, but now their ejection fraction is, say, 45%. That is truly just heart failure with mid-range ejection fraction. So how do we treat those people? The question is, well, you know, should we treat them like reduced EF or not? And the answer is nobody really knows for sure, but most people do treat it like reduced EF. And then preserved EF is not the same thing as diastolic heart failure. There's a misunderstanding out there still among a number of practitioners that think diastolic heart failure is HFpEF. HFpEF is more of an umbrella term. For all heart failure situations, the patient has the symptoms of heart failure, but they have a preserved ejection fraction. True diastolic heart failure is a stiff left ventricle that does not relax during filling. But HFpEF may include patients who have amyloid, patients who have sarcoid, patients who have aortic valve disease, other causes, not just a stiff LV.
Wow. You know, so, you know, I remember, you know, there were cardiologists, and then, oh, we got now cardiologists specialize in AFib, and that's all they do. I can see this now, that heart failure has gotten so complicated and so precise that, you know, I'm pretty sure we're going to have subspecialists more and more that are going into just plain heart failure. But thank you so much for what you did. I won't take any more of your time. I'm looking forward. I know a lot of other people are looking forward to hearing you again. Thank you, Sara Paul, Dr. Paul. And
Thank you.
for all of you, can't wait to hear more of her and basically her credentials. Oh my gosh, I'm still looking at them. I'm sorry I didn't do your service, but come and see us in October.
Yeah.
Look forward to it. Thank you.